Well, good afternoon. My name is Lisa Goodman, and I am a member of the St. Charles Communications and Marketing team. And it is my great pleasure to welcome you to today's Doc Talk. Today's topic, kids and concussions, how to play it safe. Every year, hundreds of thousands of kids in the United States get a concussion, a mild form of traumatic brain injury. And while they're common, the health impacts can be very serious. Today, Dr. Sondra Marshall and Viviane Ugalde will share their expertise on concussions, what they are, how they happen, and how local healthcare providers and schools are teaming up to better identify, treat, and children who have one. A little bit about our speakers today. We're very lucky. We have two wonderful experts. Dr. Sondra Marshall is a licensed psychologist who has specialized training in pediatric neuropsychological assessment. She earned her doctorate in 1997 from the University of Utah and helped establish the Central Oregon Concussion Program. She works closely with researchers at the University of Oregon, as well as national experts, to ensure the safety of youth in our community. She's also the division chief of our PEDAL program, which stands for Programs of Evaluation, Development, and Learning, a clinic at St. Charles that serves children in our community. Dr. Viviane Ugalde is a fellowship-trained physical medicine and rehabilitation doctor, at the center and has a subspecialty certification in brain injury medicine. Her clinical focus is neurological rehab with a special interest in biomechanical sports research. Dr. Ugalde has practiced concussion management since 1990 and runs weekly concussion clinics to help coordinate care for both pediatric and adult patients. She's a board member of the statewide Oregon Concussion Awareness Program and a medical consultant for the OSAA and advisory board member for the U of O's and CDC's Return to Learn grant. So very accomplished experts on our call today. So I'm very excited to turn the time over to Dr. Viviane Ugalde.
Thank you so much, Lisa. And thanks everyone for coming in, listening to us today. And I'll just dive right in. Today, we're going to be talking about concussion and some very important, I think, common questions that parents and patients will ask me in the clinic. We'll define what a concussion is. We'll look at what second impact syndrome is, look at some of the consequences of brain trauma and whether concussion is related to chronic traumatic encephalopathy. We'll do a description of what our current Central Oregon Concussion Management Program is, who are some of the key players, talk about baselines and whether you need them or not, look at some of the outcomes that we have from our high school program, and look at a case study as well. And then we'll also be discussing a little bit about what the CDC grant is and what it's studying in our community. Lisa mentioned that there's quite a few concussions across the country that are treated every day. We see them a lot in our ERs as well as our athletic trainers in our high schools, and the school nurses see quite a few as well. Here are some of the reasons why adults suffer concussions, and falls is the number one, particularly for our older adults. Motor vehicle accidents are common for both adults and children. Here's the CDC definition of a concussion, and it's a traumatic brain injury that's usually involved with some sort of a mechanical blow or bump or jolt. Sometimes in a motor vehicle accident, it's just the acceleration and deceleration from the whiplash of the head on the neck. You don't always have to have a loss of consciousness with that. So you don't always have to get knocked out to have a concussion. And these brain changes cause internal injury to the nerve cell. Because it's inside, oftentimes we can't see that injury as it's not a hugely structural problem. And so a brain CAT scan or an MRI of the brain is not always going to show that damage. This is a slide that Dr. Jerry Joya in Washington, D.C., who is a huge supporter of our program and has been out a number of years to give talks, has shared this slide with us. And it's important to know that our knowledge of concussion is continually evolving. And so some things I say today may not be true even a year from now. So it's always good to check in and see what the latest data is showing us. One of the things that I wanted to tell you about is that the brain will move inside the skull. So if you look at this X-ray of the two football players, you can see that the brain is sitting inside the hard skull here, but there's space around it and there's fluid. And this brain, when it impacts, can slosh around inside that hard skull. And that motion is thought to be what causes the concussion. And so if you look at this, this is from Wake Forest School of Medicine. And again, this is a slide that Dr. Jerry Joya shared with us. And this is a specialized kind of visualization of the brain. And you can see that with a impact or a sudden deceleration of the brain, you can see that there's this motion of the nerve cells within the brain when, for lack of a better word, it's sloshing around inside your skull. And here's another example of how there's motion of the nerve cells within the skull when it has that type of an impact. I need to get out of this thing here now. So one of the things about a brain cell, so this is the anatomy of a nerve cell here. And these axons here are the connections between this cell center here. And it's where it's going to terminate and connect with other nerve cells to transmit that information. And you can see that typically cells are very small, but nerve cells are actually quite big. So they're anywhere from 1 millimeter to 100 millimeters, and 100 millimeters translates out into 4 inches if that's a little bit easier to visualize. So when you have that motion that we showed on the other slide, internally here, these axons are super long. They can have some shearing injuries to the internal components of the cell, which leads to some injury. And so as a result of that injury, there's these huge changes in potassium and calcium and the way they flow across the cell. And chemicals are the way that nerves talk to each other and cause different cell reactions. And so there's all of these things that can happen. And it's illustrated a little bit better in this slide here, where you can see here's the time of the concussion. And this is the percentage of normal. You have this huge increase in the amount of calcium that flows into the cells, and then and potassium initially within these first few minutes. And the other thing that you can see here is in this black line is the amount of blood flow that's going to the brain. And you can see it declines from normal and it stays suppressed for days. And in this particular sample, looking at collegiate players, it didn't come back to normal until 10 days after the concussion. So there's changes in the physiology and the function of the brain that happens after a concussion. Why do we care about concussions? And of course, there's the obvious one that, you don't feel well, you have headaches, things aren't going well. But the thing that's changed a lot of the recent legislation in our Congresses across the states is that kids were going back into play, even though they still hadn't resolved the concussion. And our information about concussions have evolved to have us understand this better. And if a kid goes back into play when they're still concussed on that same day, within that first 24 hours, they're at risk then for this sudden dilation of the blood flow to the brain. There's too much pressure inside the skull now because it's a fixed space. And if there can be bleeding as well that could be associated with that, then what happens is that the brain then has to go somewhere. And so then it causes what's called a herniation out the end of the neck and basically the brain stem. And you have basically death or a catastrophic brain injury. And that's what happened to Max here in the state of Oregon. And that led to Max's law, which basically said we have to educate our coaches and our players to understand what the symptoms of concussion are so that that child gets pulled out of play and doesn't go back into play that same day. And this is, again, something that we educate our coaches every year as a result of that law. We were already doing that, but now it's mandated throughout the state. And it's actually in all 50 states now. And because of that, we don't really see much of this second impact syndrome much. Now, sometimes if a person has another concussion like a week later, like let's say they're dizzy, they fall, they trip, and they hit their head, sometimes that can lead to symptoms lasting longer than just having the initial concussion. So it's not good to have concussions close together temporally, but you're not going to have that catastrophic type of injury from within that first 24 hours. So I think that's an important distinction that people need to understand. And we do want to prevent recurrent concussions. That's not good, but that second impact syndrome in that first 24 hours is the one that we really try to prevent. And we've been doing a pretty good job of that, particularly with that legislation helping to educate folks. The other question I get a lot of is like, oh, my kids had a concussion. If I put a special helmet on them, if I give them this is called a Q collar that you'll see sometimes kids using in soccer. The data is not conclusive in terms of that preventing a concussion. And the problem is that that's that brain sloshing around in the skull that these special padded helmets and these Q collars do not prevent. One of the things about football helmets that's been key to note is that they do prevent a skull fracture, or like a ski helmet, for instance, will prevent a skull fracture. If you hit a tree, it's not going to prevent 100%, but it's going to drastically reduce a skull fracture. It's going to drastically reduce a brain bleed where you have big hematoma putting pressure on the brain. It does not prevent that sloshing of the brain inside the skull. And so these things really aren't helpful in preventing concussion. One of the things that's been helpful has been rule changes that you've seen, like in the NFL, and for reducing the severe brain injuries and the number of concussions. I'm sorry that's being covered by that football helmet, but basically, I just wanted to let you guys know about this and to understand that this is still in the process of evolution. They're still trying to find equipment that may be in reducing concussions, and there is some evidence that they're getting there, but still, as of today, there is no helmet or Q collar or any other equipment that will prevent a concussion. Sondra, I'm going to let you take this over now.
All right, thanks so much. It's a nice opportunity for me to say, since we've been working together, Bend has been on the map in terms of managing concussions longer than any place west of the Mississippi. So we've worked really closely with the folks that have been piloting all of these programs that help us do assessments of students with concussions. And so we feel really lucky to have Dr. Ugalde and to have the team of folks that we work with in this community. When students are referred to neuropsychology, to someone like the Pedal Clinic, we often see students with a constellation of symptoms, and I say students, but adults as well, who experience symptoms in these areas, in these key areas. So kind of thinking areas, more somatic or physical areas. We're going to talk a little bit about mental health. There are also the physical kind of contributors or the symptoms that Dr. Ugalde will also speak to. And we really wanted to highlight sleep. So when students come in to see someone like me, we do a really comprehensive developmental history to really understand how a student functioned before the concussion and how they're functioning now. Symptoms that are often associated in the cognitive domain are complaints such as a student will say they can't pay attention, they can't concentrate, their thinking feels foggy, they're not processing information quickly. So it's almost like that their hardware, if we were to relate it to a concussion, has slowed down and they get overwhelmed with information. And even doing things that brought them joy, maybe parents not so much joy, such as playing a video game, takes a lot of effort and creates physical symptoms. So these kinds of things can clear up quickly, or sometimes they persist, and that's when we would get involved. Dizziness and balance and even visual issues. So for example, someone might say they're seeing double vision, or things are blurry, or every time they stand up, they get really dizzy, or alternatively, if they lay down, they get really dizzy and it takes a while to clear. And balance also is something that we are really focused on, because if someone has poor balance, then that places them at risk for another fall or injury. Anxiety and depression symptoms are really critical that we understand how a student or a person functioned before the injury, because we have learned, one of the things that we've learned over time is that these mental health concerns, anxiety, depression, and other conditions can actually slow down or interfere with the recovery. So we need to actively really get in there and develop interventions to support that person in returning back to baseline. Nausea, headache, and fatigue may clear in and of themselves, but if there's a pre-injury history, for example, of headaches or migraines, again, those are the things that might get complicated after the injury. And then sleep. And again, we're going to spend a slide talking about sleep because it is so critical to the recovery from a concussion or mild traumatic brain injury. Okay.
So I'm just going to talk a little bit about physical activity after concussion. And initially, when I started here 14 years ago, the standard of care was to tell people with a concussion to go lie down, rest, turn off every light and electronic screen, and just stay that way until you feel better. And more recent studies have shown that that's not the best advice, and that resting the first 24 to 48 hours, up to maybe 3 days, makes some sense. But then gradually trying to resume normal activities and stimulation is actually better for your brain and helps you recover quickly. And this was found in a study that they looked at children, adults, and veterans who were returning from the conflicts with lots of concussions. So that is definitely a very important key, and regular physical activity enhances that blood flow. So CBF stands for cerebral blood flow. And Dr. Leddy at the University of Buffalo has done a lot of studies looking at if you can specifically test an exercise stress, you can give a specific exercise prescription to a person to help them resume activities and manage their symptoms. Because sometimes exercise will trigger a headache, and we want to figure out where that threshold is that they can exercise more safely and comfortably. Sondra talked about vision and vestibulo. So vestibulo-ocular symptoms are the link between our inner ear and those balance centers along with our eye motion. And oftentimes those can get affected, and we will rely on our neuro-optometrists in town to help do further in-depth assessments and come up with some vision therapy and perhaps some lens changes. One of the more common things is that if you're wearing bifocals as an adult, to go to a single lens. Sometimes we'll help kids if they're having trouble focusing on things closely, to use like just a simple 1+ reader to help them focus. And these vision symptoms can often impact headaches as well. So it's important to review that. Sondra talked about some of the more common symptoms that can be associated. We see a ton of headaches, and I'll go into that a little bit more detail in terms of specific to our community. But there's lots of different things that can be used to help manage headaches. And actually, one of the things that I have found that has been the most successful and the most tolerated and an easy first step is to use high-dose vitamin B2. It was originally studied in migraines, and I have found through my treatment of thousands of kids and adults with post-traumatic headaches from concussion that this high-dose vitamin B2 is successful at reducing the intensity of the headache as well as how frequent they occur. So there's lots of things that we can use for headache management. Dizziness, we often will rely on our colleagues in physical therapy and occupational therapy. There's a few neurochiropractors that do functional medicine that also do a really good job with this in our community. Nausea is something that's oftentimes related to either severe headaches or a lot of dizziness. So again, addressing those two symptoms often calms the nausea down. There's medications, but again, we'll use things like acupressure bands on the wrist or ginger or other things to kind of stay away from medications if we can. And then for sleep disturbance, I talk a lot about sleep hygiene. and we will use sometimes melatonin. But I'm going to just stop right there and let Sondra take over the talk about sleep and concussion.
So we know that sleep is often a symptom, disrupted sleep is often a symptom after concussion. And we all know how important sleep is. There's so many amazing, wonderful, positive, healing qualities that happen during sleep for all of us. And when people, even people without concussions, have disrupted sleep or their sleep changes, maybe because, for example, they're at the Winter Olympics in China and they have a whole new time to get their body used to being in sleep, that can disrupt performance, physical performance, cognitive performance. And what we find is when we go in and we talk to students about their pre-injury sleep, there are problems already to begin with. People have moved all of their activities onto their bed. And so the brain is constantly being bombarded with stimulation in the bed. And so on a good day, when I talk to, especially an adolescent, about falling asleep, they tell me that they're doing their homework, they're on the computer, they're using their phone. And so the brain is definitely just being overstimulated anyways. And then we remove stimulation and we try to get that person sleeping. And we have difficulties, maybe because of the concussion, but maybe also because of poor sleep hygiene. So we know that we need to first do a good evaluation of someone's sleep. I always talk to parents about sleep and students as well, about having positive sleep behavior to really help that brain know that it needs to fall asleep when it's in bed. And we need to address all these things that you see here in terms of, the social demands and where a student gets to be in contact with their friends, things they need to do if they can't fall asleep, where should they work and study, what are the family's values around what happens in the bedroom. Is there a TV? Is the student's computer? Are they allowed their phone? And all of those things are going to influence sleep behavior. So even things such as diet and drinking of caffeine are going to be important to review when we talk about getting the student's sleep back on track, because it's really during that time that we see a lot of healing take place and a lot of rest, and quite honestly, a lot of learning takes place too. So we can't, and I can't today underestimate the importance of this as you even review in your own life without a concussion, what is your sleep hygiene, your sleep process, and how that affects you on a daily basis. Okay. The next thing I want to talk about, we reference this, is the risk for clinical depression. And you can see some numbers there in terms of risks of clinical depression following a concussion. And the reason we really want to emphasize this isn't necessarily that if you have a concussion, you're going to get depressed or anxious or worried, but we need to evaluate depression, anxiety, and trauma, because sometimes the mechanism that someone sustained the concussion could have been traumatic for that brain, if it was a motor vehicle accident or the way that injury happened on the field. Or other potentially, because we know that we have concussions that we deal with when there are abuse situations. So we have to go in and evaluate that. And then we have to really set that person up for an intervention plan that straight on addresses depression, anxiety, and possibly trauma, so that it doesn't complicate the recovery. If we just focus on the physical symptoms of a post-concussion recovery, we're missing something that might actually prolong that recovery downstream. And I think the other thing that we want to talk about, and I'll let Dr. Ugalde talk about the treatment if it's persistent or long-standing depression and anxiety, is that even a parent or caregiver's response to their child's concussion can kind of influence and bidirectionally kind of complicate how the student even perceives their concussion. So I know as a parent, my son had definitely several concussions on the pitch, and I had to manage my anxiety because I knew that my anxiety was kind of influencing his own beliefs also about his recovery. So we talk about with parents about kind of how they're managing their worries when a child describes any somatic symptoms, or maybe they're taking longer to get into school or back up to speed with school. All of that relates to kind of the energy around that, managing the mental health of the student who's sustained the concussion. So extremely important. We find some of the most difficult cases that we have in terms of helping a student get back to baseline isn't necessarily because the mechanism that they got their concussion was complicated. It's more that they maybe had some premorbid depression, anxiety, maybe there was a history of trauma, and then managing everything afterwards, it can get messy and complicated. And what's driving what? Is it concussion? Is it depression? Is it anxiety? And unless there's a real pathway of intervention to very transparently and frankly managing that, it's sometimes hard to tease apart. Thank you.
Well, just to comment on a treatment for that, we definitely rely on our psychology and social, mental health, behavioral health counselors in the community. And occasionally we do have to resort to treating with an antidepressant, but we do try counseling first and activity management to try to manage that. But sometimes patients do need to take that next step in therapeutic management. This I just put on here because we hear about chronic traumatic encephalopathy, and there's a lot of questions about, if I have a concussion, am I at risk for this later on? And sometimes there's just tragic consequences from this condition, and I know you've all heard about this in the press. So one of the things that researchers have been doing, and particularly I just attended a lecture by one of the physiatrists who is working with the Brain Trust at Harvard and looking at all of these NFL brains that have been donated for study. And they've been working with persons with multiple concussions and injury as well that are still living and not having this confirmed diagnosis, because CTE is only confirmed by autopsy. Right now, we don't have a way of imaging it yet to diagnose it. But anyways, long story short is that a single concussion has not been associated with the development of CTE. So that's important, I think, for reassurance, because there is that fear out in the community now from just some of the things that we've been hearing that you might be at risk for that. And this has been fairly conclusively stated in the most recent literature. One of the things that they have been finding that multiple concussions can be associated with headache syndromes, cognitive defects, deficits, which means like trouble with maybe long-term memory and executive functioning, as well as depression and anxiety, which Sondra just talked about. So even a full recovery, sometimes folks down the line might have some issues with depression and anxiety. And we're still trying to work out that connection. It's definitely there, but we still need a lot to learn. So the bottom line is that typically people get a full recovery. Sometimes it might take a person longer, again, depending on their history or maybe some genetic factors, but typically you recover and you won't have an association with the chronic traumatic encephalopathy. What they have been finding for the chronic traumatic encephalopathy is that it's typically taking multiple blows that are what they call subconcussive. So you don't, really have a lot of symptoms. You don't get knocked out, but an NFL professional football player will have 10,000 subconcussive blows by the end of their career of playing football. And so they think that is much more the mechanism of developing CTE rather than 1, 2, or 3 concussions. They are trying to develop different techniques with MRI to help diagnose this chronic traumatic encephalopathy, but it is still in that experimental phase, and we don't have one yet, but it's hopefully coming soon. And this is just a redundant slide. I'm sorry, we talked about chronic migraines and anxiety, depression. So now what I wanted to move on to in the last few minutes that we have here is that in Central Oregon, we have this concussion traumatic brain injury management team, and we've worked hard. Sondra and then Sue Hayes over at High Desert Educational Service District have been working for years before I got here. And then for the last 12 years or so, I've been a part of that team as well. And so we consider all of these persons to be a part of the team. There's a lot of interplay between the student, the school nurse or the athletic trainer, the counselors, the teachers, the coaches, and then the medical personnel that are treating them. So we're trying to increase our education for the medical community. And that's been our goal. And we've been making some good inroads, but we still have a lot of room to improve in that area, because there's always new people that come into the community. And so we do constant education. And then this is just another representative of how a student with a traumatic brain injury might interface with all these folks. And we try to have good communication between all of these people so that we know what's going on with this kid and can maximize and improve their overall outcomes. So for instance, in this case study, we have a 14-year-old freshman who has had her third concussion from rugby. She was originally seen by the school nurse and the neuropsychologist at the pediatrician's office, and then was referred to the multidisciplinary concussion clinic that I run for persistent symptoms. And that evaluation then led to speech therapy, physical therapy, and optometry and counseling to help manage all of her symptoms. We had to do a few medication trials for the headaches that just were really persistent. And Sue Hayes and her colleagues over at High Desert Educational Service District acted as a school coach to interact with the teachers to help do some modification of the students' classroom work so that she could still participate fully in school and not get behind in her classroom work. And then we did have an eventual neuropsychological full evaluation to see where the brain function was working well so that we could capitalize on that to help her function better, and where she was still having some deficits and difficulties where we could then develop some compensatory strategies with our speech pathologist. So that's how that particular student moved through our community. As a result of us all working together, one of the exciting things that happened a few years ago that was put on hold because of COVID, but has now been reinstated, is that the University of Oregon has been funded by the CDC to look at our coordinated program and compare it with school districts in Ohio who don't have this coordinated program, to see if we really are getting our children back into school more quickly and having better outcomes. So it'll be interesting to see, but I suspect that there'll be some things that are improved and some things that we still need to work on to improve our program. But we wanted to let you guys know that that was going on, and we're pretty excited about that. This is probably very hard to read, but this is a form that Sondra and Sue developed early and got some input from the Mountain View High School teachers and students, as well as counselors, to develop this recommendation on what are some things that we can modify to help a child get back into the classroom more quickly and not just stay at home. Because we know that if a child stays at home for a prolonged period of time, it's harder and harder to get them back into school. They lose key learning opportunities and maybe even have to be held back if that is of a huge duration of time out of school. So with these modifications of allowing them to maybe have earplugs or stay out of band or choir for a few weeks while they're recovering, they will do better and get back into the class more quickly. The other thing that we do in our program, and this is kind of how it all started, was that, we had baseline studies with IMPACT, which is a neurocognitive test that's taken that looks at both your memory and your processing speed of your brain. And it allows us to be able to to then do a test after a concussion and see if they're fully healed, to have confidence that when that child is going back to play, that they're fully healed and cleared and ready to go. So this is what we've been using in our community now for close to 15 years, and it has multiple studies and validity on its use. We have in Desert Orthopedics has been instituting this SWAY online test, and I'll show you a picture of that. There's other areas where you can get more in-depth baseline testing through our clinic. And there's even some online things that you can do yourself if you want to get the app. This one I haven't seen validated in the medical literature, and this one has. But anyways, there's a lot of evolving things to help with understanding what our baseline cognition is, so that we can identify and understand that we are concussed for one thing, and also have we improved and gotten back to our baseline so that we can then return to the activities that we enjoy without a risk of recurrent concussion. Now, there's controversies about impact. Some kids might sandbag or deliberately do poor performance on their baseline. There are some validity testing that we can help to prevent this. And there's just a list of things, but overall, it's a reasonable test to use in managing concussions. This is just a picture of the SWAY. You can see maybe they're holding their iPhone at their chest and they're doing some balance testing, and they have some cognitive testing. And this is showing it doing it in a big gym. It's somewhat expensive right now, so we're not implementing it just yet, but we're checking in to see if we can get a technical grant to maybe cover the cost and do it to see if this is an appropriate intervention for us. What are some baselines that are available in Central Oregon right now? Well, there's computerized based testing with the impact for ages 12 to 80. You can get a baseline here at the center. We do the pediatric impact as well. We also do these for post-concussive assessment in our concussion clinic here at the center. We have at Therapeutic Associates an advanced balance testing. SWAY is available through Desert Orthopedics. And then we have this King Devic visual processing test that we can do as a baseline as well through our clinic. I don't have, let me just see here. I've got about 7 minutes. I just want to let you know that one of the things that I have been doing since I've taken over as medical director of the concussion program here through the Center Foundation is to look at the data. How good of a job are we doing? Are there areas that we can improve? And so one of the things that I've done is compare it to some previous studies in the literature that talk about how a lot of high schools across the country have recurrent concussion rates that rate between 14% to 7.3%. And these are all improving after they've implemented those laws that I was telling you about Max's law to pull kids out and train coaches. And basically from 2011 all the way to 2019, our recurrent concussion rate has been about 6 to 6.6%, which is lower than most of those high schools across the country. And I think it's because, as Sondra said, we have been an area that's been implementing concussion management for quite some time. And so our teachers and our schools and our coaches are used to implementing these concussion protocols, and it has been effective at keeping that recurrent concussion rate down. The other thing that I've been looking at is, because there's not a lot of literature out there, is just what do we do with kids that have persistent headaches, and what can we do to intervene? How quickly are we getting kids back into this classroom? And so this group of 97 kids that was over a 1-year period, we found that kids had headaches that range from 1 day of headache to 670 days. But if we take that one kid that had headaches for 670 days out, the average was about a 9-day headache. They also were back into the classroom within 10 days, typically as a mean. And they were able to return to play without restrictions, and 28 days was the average for our kids going through the protocol. Some of the things that we're expanding is trying to incorporate more and more high schools in the area and coordinate our communication with Desert Orthopedics, who handles the Redmond schools. And so we've been trying to have a standardization of all of our protocols, as well as trying to get into middle school football. And then, of course, HDESD with their efforts and their donation of time and free school coaching was able to show the value of that. And the school districts are now funding school coaches to keep our kids in the classroom. So in summary, we have concussions that can occur that do not require a loss of consciousness. We have a concussion protocol in Central Oregon that's returning children to play safely, and our recurrent concussion rates are lower compared to the rest of the country. Although the rest of the country is getting close to that level now because they've all implemented those MAX's laws. We have baseline testing and specialized testing available in Central Oregon. If you have an interest or you have a child who's particularly active and in a high-risk sport, they might want to come and get some baseline testing. Because a child's brain develops over time, those baselines unfortunately don't last more than 1 year for a child less than 12. And once every 2 years is what the recommendation is for children over the age of 12. We have concussion clinics and coordinated clinics with multidisciplinary folks there to help coordinate that care. And hopefully we're returning kids back to the classroom faster. We'll find out when the CDC study is complete. And then finally, a single concussion is not associated with chronic traumatic encephalopathy. I think that, Sondra, if you want to talk a little bit about this, because I think I've taken the lion's share of the speaking. If you want to just give them a little bit more information about the CDC grant and let them know what we're doing there.
Sure. So as Dr. Ugalde mentioned, we work with the University of Oregon, and right before the pandemic, we learned that we received a fairly substantial CDC grant to really look at our Return to Learn project. All the time that Dr. Ugalde mentioned that we've all put into this to grow this over the last 15 years resulted in the CDC acknowledging that and possibly, really holding our community up as a national standard. It's not easy to do. Providers always change, systems change, insurance changes, but we are doing, I think, a really good job. So if you have a student, a child who has sustained a concussion, and you would like to be part of this study and to give your very frank and transparent, honest feedback about what your experience was like from point of injury, getting back into school, we need to know. So here's the information. You do receive $50 for participation. There's opportunities to be in an interview, and from the parents, the student can be in an interview, and we rely on you to really inform us about how this went for your student. So you can call the number that you see at the bottom of your screen. You can also reach out to Dr. Ugalde or myself if you have any questions.
Well, I think that we went through some of those slides fairly quickly. And I'm happy to, and Sondra is happy to answer any questions that there are in the chat.
Great. Well, thank you both for a wonderful presentation. Lots of good information in there. Some of our follow-up questions. So a child is injured playing a sport and potentially is concussed or has some other kind of traumatic brain injury. What are next steps? So are there acute symptoms that would prompt you to want to take them to an emergency department to be evaluated right away versus take a wait and see approach and see how they fare in the coming days?
Yes, so the CDC has a very nice website called Heads Up. And on there, it has a list of what they call red flag symptoms. So if a child, first of all, if a child has been knocked out, that's number one, that they should be taken to the emergency room for an assessment, because again, in that first 24 hours, you want to make sure that they're not having bleeding in the brain that could cause pressure on the brain. And so being knocked out is one of those things that is key to having a further assessment in the ER. Now, if a kid is just transiently for a few seconds out and it comes to right away and is answering questions pretty reasonably, They don't look too confused. I think that's one where you could probably, watch and check them every hour to make sure that they're not having any deterioration, like they're not becoming more confused or disoriented. But if someone's definitely knocked out for over a minute, for sure you want to take them to the emergency room. If your child isn't knocked out, but they are super confused, they don't know exactly where they're at, they don't recognize the people around them, that serious confusion, again, is another reason to take them to the emergency room. Other reasons would be progressive severe headache with nausea and vomiting that just keeps going on so that they can't really control their vomiting. You want to get them to the emergency room right away. Sometimes you might see some asymmetry to their pupils. So in other words, your pupil sizes are different. And then, there's a couple of other ones that are listed on that list, but those are the ones that I think are really key to go to the emergency room right away. Now in the high school, we have the benefit in Central Oregon of having athletic trainers available on site for kids to be evaluated during practice and play for the most part. The elementary school kids get evaluated by the school nurses, and they have been trained by us to go through a symptoms checklist, which is, I think, really key at helping to identify symptoms and identify if a kid has had a concussion or not, and to notify the parents. And hopefully you get sent home with that checklist as well, and in terms of monitoring. And if a kid is having persistent symptoms where they're out of school for more than a week, I would say definitely see your primary care physician right away. And then, of course, we have a walk-in clinic at the center. It's called Now Care, where you can get assessed immediately, or be seen at the concussion clinic for persistent symptoms as well. So those would be, I think, the steps that I would take for those types of symptoms.
And if I could add, I think sometimes, because we're, kids will get better, but it's always good to let the teacher know and let the school know if a child's had a bump on the head. And that way they can be aware of any changes in behavior, especially a student might seem okay, and then they go to school where they have to actually use their brain and, use all that cognitive, there's all that cognitive demand. And then all of a sudden there'll be symptoms there that weren't expected. So it's important that the school knows.
Great point. This is a good question. So Dr. Ugalde, Dr. Marshall, knowing what you do about concussions, would you let one of your own children play football or another sport where there's a high likelihood of concussion?
I think, yes, I'll go first. I mean, I think I would definitely let my child play. And the reason I would is because they've never had a concussion before. And some people's brains are just, again, more resilient to that type of injury. And so I think if they had a concussion, that would be a different conversation. But if they've never had a concussion and they want to play sports, I think that to this date, we don't have enough information to say that football for an individual is a no-no. Now, as that genetic research and the more information comes out from the NFL studies, we may have a more specific answer to give people in terms of which kid might be able to manage football more than another.
But you raise an interesting point, which is maybe it's not a static decision, right? So if your child is playing sports and doesn't get a concussion, they're probably doing just fine. If they're playing football and they get a concussion and maybe a second concussion, then maybe that prompts a conversation about, do you continue to play football? Is that an accurate way to kind of describe what your answer?
Absolutely. It's definitely a dynamic discussion, and there are multiple factors that go into deciding if a child has had recurrent concussions, what type of activities would be safe. And one of the sports medicine physicians that runs the concussion clinic at OHSU, I thought, put it really brilliantly. And what he does is has a frank discussion about what we know about what happens with recurrent concussions and the possibility that you could have more persistent symptoms of like, chronic migraines or difficulty with that frontal lobe executive functioning, making decisions and that sort of thing. And the risk of the individual sport. And so sometimes if somebody's a football player, let's say they were like a lineman with a high risk, well, maybe they could be a kicker instead, where there's less likelihood of impact of any sort with the kicker. It's not 100% reduction, right? But it is a reduction in risk. Or changing a sport to something like, swimming or tennis over soccer for a girl. You know what I mean? So you have discussions like that where you don't want to withdraw all activity, but something that maybe reduces your risk would be appropriate in that setting.
Great. So we're talking about kids, so a pediatric population. Are there any effects of concussion that are unique to children that we don't see in adults? And secondly, are children at higher risk for longer term problems because their brains are developing and then they sustain an injury? So is there any risk of long-term health problems because of their age at the time of concussion?
Yeah, that's a little bit of a controversy because there have been researchers in New Zealand, for instance, who they have the advantage in New Zealand is they have like one health record and everybody has both academic and health records linked there. So the study was able to follow children with more than one concussion over the years and found that they didn't really have any significant reduction in their academic performance. Things went well for them. They really didn't find any long-term outcomes that were poor in that particular group in New Zealand. Now, there are studies that show that if you have a significant injury under the age of 3, like a kid who was in a car accident and had a big brain injury, that puts them at increased risk as an adult if they get another concussion, that they might have prolonged recovery and maybe even an incomplete recovery. Other than that, it's somewhat controversial, and it's definitely, it makes some sense. I mean, kids that are developing take longer to recover. If they compare elementary, high school, and collegiate players, the collegiate players recover more quickly than the high school players do. So there is some differences there. And Sondra, I think that Jerry Joy has some data on that. Have you read his recent papers?
I haven't, but here's what I'd like to say. There is controversy, and part of it, and this was presented to us by Dr. Kevin Guskowitz, who was actually really instrumental in changing the punt return in the NFL based on his research and kind of the G-force that happened. He put sensors in helmets and just saw how much G-force it takes to even create a concussion. Kids these days, the way we play sports has changed since I was a kid. So kids have much more opportunity. They start at 9, they're playing their sport almost year round, taking very little breaks. So they have, and this is what Dr. Ugalde identified as the subconcussive threshold hits. And they have opportunity to have many more of those. So I have a son who had 3 concussions on the pitch. And I remember at each step of the way having a conversation, when do we take a break and when will we know? And it's not an easy conversation to have. And it's one best guided by someone who's kind of not emotionally, kind of charged and kind of just has the data. And I myself, we live here in Bend, Oregon, where there's a lot of opportunity to get concussion in our very busy athletic town. And I certainly have had my share of them. And so I think we just have to be careful when it's not a black and white conversation. And in terms of the long-term outcomes, there's constructs called plasticity of the brain that kind of get integrated into the conversation. And for me, very clinically, what I've learned is that if a student takes a long time to return to baseline from one concussion, I get more anxious about what the next concussion might look like if they get another one. So that kind of what their post-concussion recovery curve looks like I don't
Mhm.
know, Dr. Ugalde, if that from a clinical standpoint makes sense to you, but that is what sometimes gets me anxious, as well as the mental health of that student.
Hmm. Okay, great. Let's see here. Another viewer question. What is your experience with mindfulness for post-concussion syndromes? Is that something you recommend, or is there evidence to suggest that is efficacious in helping a child recover from a concussion?
Uh, any specific, I have not seen any specific papers on that, but we definitely use different things like Sondra can probably tell you a little bit more about this, but there's like apps that kids can put on their phone, like Super Better and Beatfulness. And there was one called the Concussion Coach that was actually developed by the Department of Defense. It's now off, but those are ones where you can spend some time meditating daily and using that to help modulate their anxiety symptoms. So they give lots of good tools and tips on how to manage that on a moment to moment and day to day basis. And I will definitely make recommendations with that quite a bit. It's a little bit tough because you have to remember to use them, and then you have to look at the screen as well. I think that's an area that we can definitely improve upon in our community with just access to programs like that kids can learn from.
Access to programs, and also just access to, like Dr. Ugalde mentioned, the right professionals, because some of the mindfulness work is that the symptoms are painful, they limit quality of life, and there's a worry about how long are they going to continue for, and it worries the student and it worries the parent, and so then that snowballs into kind of impacting the full recovery picture. So that's why, in terms of working with a concussion team, that is really important to be assessing and monitoring over the course of the recovery.
Great. And it looks like a comment from one of our viewers in the same vein. This person said, I practiced, quote, yoga for your brain in a small group class at the yoga lab in Bend. Love Your Brain offers free classes throughout Bend virtually. So it does sound like there are some interesting groups focused on mindfulness and the brain in our community, which is interesting. Another question. My child didn't lose consciousness. Does this mean they didn't have a concussion?
So that is not true. So you don't have to lose consciousness to have a concussion. And again, the other symptoms that a child might show initially would be that they are a little bit dazed, they might be confused, or they might develop some symptoms of headache, particularly with mental or physical activities or some of those other symptoms. So absolutely, you do not have to have a loss of consciousness to have a concussion.
Okay, great.
And you don't have to have, like a lot of parents will say, well, their pupils weren't dilated, so they didn't have a concussion. So that's just another, I think, myth to clear up. And, sometimes when people have concussions, they aren't necessarily initially diagnosed because they aren't symptoms, or maybe there were orthopedic, like leg breaks or arm breaks, and those were taking kind of the focus. And then when someone goes home, all of a sudden they get symptoms. And that it's very possible that there's a delayed diagnosis of a concussion, just depending on how the mechanism of the concussion and what else was going on.
Okay, good. Great information. Well, looks like we have time for maybe one more question. Dr. Ugalde, you mentioned earlier in the presentation the metabolic injury that occurs with a concussion. And this is a really interesting concept. I know for me personally, I envisioned a concussion occurring when, the brain hits the skull and maybe there's damage to that tissue. I didn't really ever think of it in terms of the metabolic function of the brain. So that's an interesting concept. That being true, is there any kind of test on the horizon to determine whether someone has experienced a concussion based on those metabolic changes? So if we know X, Y, and Z changes with concussion, is there anything in the pipeline in the future that would help us gauge those changes and perhaps indicate concussion beyond just the presentation of symptoms?
Yes, there's a thing called functional MRI that's on the horizon, and they're doing it in terms of a research basis at like the University of Washington, but it's not worked out to where we know how to use it clinically yet and how to apply it clinically. But that is an image that doesn't just look at the structure. So a regular MRI would just look at the structure. Where are things? Where's the blood flow? Where's the spinal fluid? What does that look like? It's just looking at the anatomy and the basic structure. Functional MRI looks at the function of the brain and how it's working. And so that is on the horizon. There's a couple of other types of imaging that show some promise as well. So hopefully things in the next few years will be really much more clear in terms of helping diagnosis and then following that recovery as well.
Great. Well, that's exciting research. So more to come. Well, great. Well, we would like to thank everyone who joined us today, and a huge thank you to our speakers, Dr. Sondra Marshall, Dr. Viviane Ugalde. Thank you so much for sharing your time and your expertise. If you'd like to watch this again or share this presentation with someone you know, please feel free to visit our Doc Talks page on the St. Charles website, stcharleshealthcare.com. And also feel free to look back at our social media channels. We'll have it posted there as well. So thank you again to our speakers and to our audience. And we hope you have a great rest of your day. Take care.
Thank you.